Welcome to my YouTube channel. Today we are going to talk about diagnosis and treatment of asthma. So, diagnosis, as we all know here, diagnosis we start with history and examination. So, history, the typical symptoms of asthma, that is shortness of breath, wheezing, chest tightness, and dry cough, among other symptoms. This is just a table just to show you what you will ask in your history, and that will help you to identify if this is asthma or not. So, absence of signs and symptoms of asthma and clinical history suggestive of asthma, then you look for alternative diagnosis. So after taking a good history, the next thing that you're going to talk about is the investigation. So if you know the pathophysiology of asthma is characterized by three characteristics. That is the inflammation of the airway and remodeling of the airway hyperresponsiveness, and airway limitation or obstruction. So in terms of investigation, you have to confirm the presence of airway limitation. So that is you document the FEV1 and FEVC. FEV1 and FEVC is reduced by less than 0.5. Then afterwards, this will show you that this is airflow limitation. Kindly note that there are other obstructive or airflow limitation diseases, COPD. So this does not conclude that this is asthma. So the next thing you do is to check, is this limitation or obstruction reversible? If reversible, then it is asthma. If it is not reversible, then it is most probably COPD. So then how do you check reversibility? Reversibility, you give the patient a bronchodilator, and if it is reversible, that the FEV1 or FEVC improves by greater than 12% or greater than 200 ml, then that shows that this is asthma. So the tools used is spirometry and the peak expiratory flow rate. So in terms of spirometry, as you have said before, it should decrease in FEV1 and FEVC ratio, that it should be less than 7, and this is just an indicative of obstructive nature. And as you have said before, when you get a picture of obstructive nature, you think of diseases such as asthma and in addition to COPD. So for you to conclude whether it is asthma, the airway limitation or airway obstruction in asthma is reversible. So you give a bronchodilator, that is beta-2 agonist. And then the agonist, if it will increase the FEV1 or FEVC by greater than 12% or 200 ml, then the airflow is considered reversible. Then this is asthma. However, if it is reversible, then we consider it as COPD. So this is a very good flow chart just to help us in terms of diagnosing of asthma. So we already said that in this class or in this academy, we normally start with history in terms of diagnosis and treatment. So in history, as your patient comes to your clinic or your hospital with chronic and recurrent symptoms of respiration. So yes, are these symptoms typical of asthma in terms of chest tightness, shortness of breath, dry cough, among other symptoms? Yes. Then you take a detailed history. In terms of detailed history, you're going to take drug history in terms of have they taken NSAIDs? Are they on beta blockers? In terms of allergen, because asthma is a disease that is triggered by that has triggers, for example, allergens, and among all those factors. So, do we have atopy? I have a video on asthma, so you can go and check all more on that, what you'll ask in your history. So yes, the history is suggestive of asthma. So the next is your patient taking ICS treatment? And then no, maybe this is the first time the patient is coming to the hospital. Does the patient have severely uncontrolled respiratory symptoms? This means, is the patient in acute phase or not? So the patient is not in acute phase, no. Then you do a spirometry of the two that will tell us more about lung function. So which lung function are we checking mostly? The FEV1 and FEVC. So are they reduced? You do before and after bronchodilator. I hope we are all understanding by now. Our reason for bronchodilator is to show reversibility. So if yes, then you treat with asthma, that is ICS containing treatment. So if no, you've met a patient and then these symptoms are not typical of asthma, then you look for other diagnoses. In addition to, if your history and examination is not suggestive of asthma, you look for other diagnoses. So if your patient is in acute phase, you treat empirically. If in the setting that you are is a low resource setting, you should treat empirically. And then you review the patient 1 to 3 months. For example, if the spirometry is available, then you do the lung function, or if the symptoms have improved, then well and good. And kindly remember that in your treatment, it must be an ICS containing a drug. So in management, you cannot just come for example, in an essay you are given, and then the first thing you just start because you have mentioned ICS treatment is just management, ICS treatment, and then you expect your professor will give you all the marks. No, you have to be arranged. So in management, you have to educate the patient in terms of compliance. This patient compliant to the make sure that the patient is compliant to the medication if it's the first time. If it's not the first time, then address the compliance. Next, inhaler technique. Make sure that your patient uses the inhaler before you. If it's the first time, make sure you teach the patient and then ensure that the patient using the inhaler in front of you. If it's not if it's, this patient is not a new patient, that the patient doesn't be coming on for follow-up, also ensure that each time they come for a visit that they use the inhaler, and also give the patient action plan. So control environmental factors we mentioned before, that's triggers, comorbid conditions such as obesity, medications such as aspirin and beta blockers, and infection. In terms of infection, you vaccinate. So this is just a very, very good summary, because if you understand this, the rest of the slides we are going to repeat actually. So this is a very, very good slide, which is going to tell us what is step 1, what is step 2, what is step 3, what is step 4. I have a video containing asthma, which has more details actually on two organizations, that is GINA. This is actually GINA, and we also have the NEP, that is the National Asthma Education Prevention Guide program, that has its own definitions. However, the GINA is one of the best. This is 2024, so we are going to start. So patient has come in. Daily symptoms of asthma: they waking up at night at least once or more in a week, and they have low lung function or recent exacerbation. Then yes. So you have mentioned yes. Then this is medium ICS for metral. You give the patient medium ICS for metral, for maintenance and relief. We are going to explain all this. Actually, this should come in here and also the last slide. So medium dose ICS for metral, for maintenance, and also for reliever. So if you don't have that, then you give medium dose ICS LABA plus, this is for maintenance, and then plus SABA for reliever. And then if the symptoms are most days or waking up at night once a week or more, and you still have or low lung function, then yes. Then you maintain on low dose ICS for metral and maintenance plus reliever. So the same drug you use for maintenance and the same drug you use for reliever. If this is not available, then use the alternative option, that is low dose ICS LABA is for maintenance plus as needed SABA for relieving. And then no, so the symptoms are there, yes, but they are less than 3 to 5 days a week with normal or mildly reduced lung function. So yes, so you use if now you have ICS for metral, just use as needed ICS for metral. However, if you don't have ICS for metral, then you use for step 2, sorry, you use low dose ICS plus as needed SABA. And then for, for step 1, you use low dose ICS whenever you take SABA. So step 1 is that patient who is mildly asthmatic, while this one is more of intermediate or moderate asthmatic. So you use low dose ICS for maintenance and as needed SABA for reliever. This one you just use ICS plus SABA, just low dose, as a reliever. Management. So we are just going to use the GINA. So before we manage, you have to do this. This is just what you have talked through previously. So you have to confirm diagnosis if necessary. If you're not sure that your working diagnosis is asthma, and then symptom control and modifiable risk, the risk that such as smoking, tell the patient to quit and help the patient to quit. Comorbidities such as obesity, you address them. Inhaler technique and adherence, patient preference and patient goals, as I mentioned before. So the treatment that is assessed, then adjust. So you adjust the treatment, treatment of modifiable risk factors and comorbidities. Non-pharmacological strategies you also have to dig in, and also asthma medication, that is including ICS. Each and every, like if you are given an essay and you actually don't know what to write, you must write ICS medication, ICS, and also education and skills. So in your review, you're going to review patient symptoms, exacerbations, side effects, how have the lung function improved, comorbidities, and patient satisfaction. So here we have 2 tracks, that is the preferred track and the alternative track. The preferred track, this is the track that we are going to use when, for example, you have there are no contraindication for the drugs or anything like that. So we have step 1 to step 2, step 3, step 4, step 5. We have mentioned before according to Gina and NEP, and if you have not understood, you can go back and check them. So step 1 and 2 is needed only low dose ICS for metrol. For metrol is a LABA. So as needed, you just don't have to use or maintain each and every day, but you use as needed. Step 3 is you use low dose maintenance ICS for metrol, not almost daily. And then step 4, use medium dose ICS for metrol. And then step 5, you add on alamam, that is alama, a long-acting muscarinic agonist, antagonist, and you refer for assessment of the phenotype. Also consider high dose maintenance of ICS for metrol, among other factors. So if it is phenotype, you can also give immunomodulators, among others. So for the alternative, you take ICS whenever needed. Here is where, for example, you don't have a SABA or just the alternative. So alternative step 1, take ICS whenever SABA taken. So when you take SABA, you take ICS. Then step 2, you low dose maintenance ICS. So low dose maintenance ICS. Step 3, low dose maintenance ICS and LABA. That is almost the same as this. For example, your LABA is not for metrol, maybe some other LABA. Step 4 is also maintenance, or medium or high dose maintenance ICS LABA, which is not for metrol or any other. And step 5 is an add-on LAMA. So, or refer for assessment, you also consider high dose maintenance of ICS LABA, among other drugs. You can also, other controller option, you can also have low dose ICS whenever SABA taken, as you've mentioned before. So SABA disadvantages, if you have noted that in the previous slide, you have not mentioned SABA a lot. What you have mentioned is ICS for metrol or ICS LABA. So SABA, that is short-acting beta agonist, it treats the symptoms but not the disease. So regular use of it, even for 1 to 2 weeks, should be increased. Here, increased airway hyperresponsiveness, reduced bronchodilation effect, increased allergic response, increased eosinophilic. And if you notice, all of these were in the pathophysiology of asthma. So it becomes a vicious cycle of overuse, because when I use it, it causes these symptoms. Now, if it causes these symptoms, I'm going to use it for me to treat those symptoms, but I'm not treating the disease. So this in the end causes increased exacerbation and also increased mortality. So what is the advantages of ICS for metrol? As I mentioned, we'll see a lot of ICS for metrol, ICS for metrol. So it reduces the risk of exacerbation by 60 to 64. So maintenance, that is maintenance and reliever therapy, that is ICS for metrol, which is from step 1. So if you have noticed, from step 1 to step 3. So step 1 to 2, we're just using it as needed. However, from step 3 to 5, we're using ICS for metrol maintenance, that is daily. So why advantages? It reduces the risk of exacerbation, and we have the following formulation, that is budesonide for metrol, that is 206, and for pediatric population, that is 106, and beclomethasone, that is for metrol, that is 106. So if ICS for metrol is the only ICS that can be used, is the only ICS that can be used as anti-inflammatory reliever. Do not use ICS for metrol as a reliever with any other ICS LABA. This is because of the side effects. So next, so this is just an image just to show us step 1, that is the mat. So step 1 to step 4 and 5. So if you say step 1 to step 2, just using as needed. Use one inhaler for just both. So if it's ICS for metrol, just get the one with one inhaler and use as needed. Step 2, as we have mentioned it, you have the mat, that is maintenance and reliever. So you use the same drug for maintaining, or also use the same drug for reliever. So the same drug taken one inhalation once or twice daily, and one as needed. I hope you have understood. So maintenance, meaning I'm taking it through the day. Reliever means when these symptoms become, for example, too much, then it's when I'm taking to relieve the symptoms. And this is low dose, and then step 4 is medium dose, and then step 5, if now it's not helping, now you start to refer to the expert and phenotype and add-on of LAMA, as we said. This is the track 2. So track 2 is ICS. Take ICS whenever you take SABA. This is for the case where we don't have formoterol. This is 2 inhalers taken together is needed. I hope you note. And then low ICS maintenance, and then this is maintenance. And then now you use the reliever as ICS SABA or SABA or uh, SABA alone. So 2 inhalers, but change 1 to regular use. Then step 3 is low maintenance ICS LABA. I hope you are all together. So step 3 is low maintenance ICS LABA, which you can use for maintaining or use as reliever. So you use for maintaining, and then now you use the reliever here. So you switch to new inhaler for regular. This is when you just went up the ladder for regular use and continue as needed the inhaler. So here you have an ICS LABA, and then you also have ICS SABA or ASABA. So the SABA, you use it as a reliever, and then you use ICS LABA as the maintenance. And then you also have maintenance ICS LABA, and also I hope you note. So that's why we say we prefer step 1, because you've said SABA increases higher risk of exacerbation, also increases mortality. So if the patient has the following, so this is just a very good thing. So if the patient has the following symptoms, this is just helps us in step 1 and step 2 among all others. So daily symptoms, waking at night once a week or more, and low lung function or recent exacerbation. So yes, what am I going to do? I'm going to maintain this patient on medium dose ICS formoterol, that is maintenance and reliever MAT. Or I maintain him on medium or high ICS LABA plus is needed SABA or ICS SABA. This is just a summary. Then no, so this patient is not waking up. So symptoms are most days or waking up at night, at night once a week or more, or lung function. So yes. Then you use low dose ICS formoterol for maintenance and reliever. So if you don't have this option, alternatively use track 2, that is low dose ICS LABA is needed, and plus is needed SABA, or better if you have ICS SABA. So this is symptoms. No, so symptoms are less than 3 to 5 days a week with normal or mild reduced lung function. So yes, then you just use as needed low dose ICS formoterol. Then if you don't have, as this is step 1 to 2 if you have noticed. Then if you don't have the ICS formoterol, you use for step 1, sorry, for step 2, you use low dose ICS plus as needed SABA. This is for maintenance. And then if it is step 1, you just take low dose ICS whenever SABA is taken. I hope this is actually the best summarization of the treatment.